Hi, I'm Dr. Sakashi Arora. It's my pleasure to be here to deliver a live lecture in gynecology. The topic which I have decided for today is amenorrhea. But before I proceed to amenorrhea, thanks a lot for the warm acceptance you've given to all my books: Self-Assessment and Review Obstetrics, Self-Assessment and Review Gynecology, Self-Assessment and Review ENT. Whenever I go somewhere, there are few students who come up and ask, "Ma'am, why are these books so lengthy? Why aren't they short and sweet?" So my answer to this question is that when I'm writing these books and when I'm editing, I always keep two aims in mind. Number one, these books should help you to clear your postgraduate medical entrance examinations, and which I hope all of you will do. And the second aim is you should get the subject speciality of your choice and the college of your choice. Now for that you need that extra edge, and that extra edge is provided by my books. So now it is up to you whether you want to read these books or you don't want to read these books. The ball is in your court. So coming to amenorrhea. Amenorrhea, as you know, means absence of menstruation. Now amenorrhea, it could either be physiological or it could be pathological. Physiological amenorrhea, as you know, occurs before puberty, after menopause, during pregnancy, and at the time of lactation. Now coming to pregnancy. Pregnancy, although it is a cause of physiological amenorrhea, whenever we talk of secondary amenorrhea, which I'll be telling you just after this, in secondary amenorrhea you should always rule out pregnancy. So pregnancy is the most common cause of secondary amenorrhea. Coming to pathological amenorrhea. Now pathological amenorrhea, it could be primary amenorrhea or it could be secondary amenorrhea. Primary amenorrhea, it can further be cryptomenorrhea or it could be true primary amenorrhea. Now, what is primary amenorrhea? Primary amenorrhea, literally this means that a female has not had menarche. There is no menarche. She had never experienced menstrual bleeding. That is what is a layman definition of primary amenorrhea. And secondary amenorrhea means that a female has been menstruating regularly, but now she is not having any menstruation. So coming to primary amenorrhea. In primary amenorrhea, as I told you, first is cryptomenorrhea. Cryptomenorrhea, it is a condition in which a female menstruates normally, but the menstrual blood fails to come out. Although she is menstruating normally, the menstrual blood does not come out because of some obstruction in the outflow tract. For example, the causes of cryptomenorrhea are imperforate hymen, transverse vaginal septum, and vaginal agenesis. The most common cause of cryptomenorrhea is imperforate hymen. In case of cryptomenorrhea, the patient will complain of recurrent episodes of cyclical abdominal pain plus primary amenorrhea. That means she wouldn't have had menarche till yet. On examination, now these females are normal females. Their genotype is 46XX, and because they have two X chromosomes, obviously the gonads in these females is ovary, which are functioning normally. So Ovaries will be secreting estrogen in normal quantity, and if estrogen is normal, estrogen is responsible for secondary sexual characteristics in females. So in these females, because estrogen is adequate, their secondary sexual characteristics will be well developed. Now these females, they are menstruating normally, but because of the imperforate hymen or because of a transverse vaginal septa, the menstrual blood is not able to come out. So menstrual blood, it keeps on collecting in the vagina, and then if menstrual blood collects in the vagina, that is called as hematocolpos. And menstrual blood keeps on collecting in the uterus, which is called as hematometra. So when you do a per abdominal examination, you can palpate lower abdominal mass in these females. Now when you do a local examination, when you are doing a local examination in these females, if it is an imperforate hymen, you will see a tensed blue bulging hymen. The hymen will be bluish in color, it will be tensed, and it will be bulging. You, as I told you when I was giving my obstetrics lecture, that in virgin females per vaginal examination is contraindicated. So you are not going to do a per vaginal examination. Instead, if you want to feel the uterus, you will go for a per rectal examination. Now how will you manage such a condition? In such a condition, for management, it is very simple. If it is an imperforate hymen, you simply have to give a cruciate incision onto the hymen, and whatever the collected blood is there, it will keep on draining by itself. Now when the blood is draining, please do not give any suprapubic pressure. We do not want any type of infection to develop in the uterus, because then that is going to impair her fertility. If it is a transverse vaginal septum, you simply have to excise the septum, that is excision of the septum. And if it is vaginal agenesis, you have to do a pull-through operation. So that is how we manage these females. On ultrasound, if you do an ultrasound in these females, you will see that the uterus is intact and the uterus is filled with blood. That is, you will find the presence of hematometra as well as hematocolpos. That is all we need to know about cryptomenorrhea. Coming to true primary amenorrhea. True primary amenorrhea, it means that if secondary sexual characteristics are absent, then menarche has not been attained by the age of 14 years. So primary amenorrhea means in absence of secondary sexual characteristics, menarche is not attained by 14 years of age, and in presence of secondary sexual characteristics, menarche has not been attained till 16 years of age. That is what is meant by primary amenorrhea. Before I proceed further, we are talking about secondary sexual characteristics, we are talking about menarche. So first we should come to also know about puberty in females. So coming to puberty in females. What is puberty? Now puberty, it is the state of becoming functionally capable of procreation. That is what is puberty. The age group for puberty in females is 8.5 to 13.5 years. That is the normal age for attaining puberty in females. The mean age of attaining puberty in females is around 12 years, and in males it is around 14 years. Then the sequence of pubertal development in females. The first sign of puberty in females is breast budding. That is a very, very important question, which is called as thelarchy. That is the first sign of puberty in females. The sequence of puberty in females, it can be remembered by a very simple mnemonic, and that is BPH in males. So first is breast budding, second is appearance of pubic hair, that is pubarchy, and appearance of axillary hair, that is adrenarche. H is increase in height or growth velocity, and M is for menarche, that is appearance of menstruation. Now, the hormone, the chief hormone which is responsible for puberty or these secondary sexual characteristics, these are called as the secondary sexual characteristics in females, is estrogen. Estrogen, it is responsible for breast budding, and it is responsible for increase in height of females. As far as appearance of pubic hair and axillary hair is concerned, the main hormone which is responsible for this in females also is androgen. Now, whenever breasts or pubic hair they appear in stages. That means you can classify the appearance of pubic hair and breast budding, and this classification, it was given by Tanner. Tanner has given a staging of breast development and a staging for pubic hair and axillary hair development. We do not need to know the complete staging. What is required is that Tanner said that breast, the full appearance of breast, it occurs in 5 stages, and similarly appearance of pubic hair and axillary hair occur in 5 stages. Tanner stage 1 and stage 2 means that the breast or pubic hair are less developed, whereas Tanner stage 4 and stage 5 means they are well developed. Whether it is breast or whether it is pubic hair, it is well developed. That is all what we need to know in Tanner staging. Now, next question which they ask here is, what is precocious puberty? Precocious puberty is if puberty, the signs of puberty, that means breast budding appears before the age of 8 years, or if menarche occurs before the age of 10 years. The normal age of menarche is 10 to 16 years. Normal age for puberty is 8.5 to 13.5 years. That is precocious puberty. Next question on precocious puberty is, what is the most common cause of precocious puberty? And the most common cause of precocious puberty is idiopathic. The management of precocious puberty. Now see, I told you the hormone which is responsible for bringing about puberty, pubertal development in females is estrogen. This means if you suppress the levels of estrogen, you can treat precocious puberty. The levels of estrogen, they can be suppressed if you are giving GnRH analogs. Now you will say that in the body, hypothalamus releases GnRH. This acts on pituitary. Pituitary releases LH and FSH. This acts on the ovary, and ovary secretes estrogen. So GnRH is responsible for increased secretion of estrogen. So how can GnRH be used for the treatment of precocious puberty? The answer to this question is that in the body, hypothalamus gives pulsatile, there is pulsatile release of GnRH. When you are administering GnRH from outside, you are giving continuous GnRH. Pulsatile GnRH increases estrogen secretion, but when you are giving continuous GnRH, it down regulates estrogen secretion. That is why GnRH analogs, they are being used for the management, or they are the drug of choice for the management of precocious puberty. What is delayed puberty? Delayed puberty is when the breast budding or secondary sexual characteristics, they have not appeared by 14 years of age, or if menarche has not been attained by 16 years of age. That is all what we need to know in puberty. Now once we know puberty, coming back to amenorrhea, primary amenorrhea, again the same thing. For a female to menstruate, the basic requirement is that the hypothalamic pituitary ovarian axis should be intact, because hypothalamus releases GnRH. This acts on pituitary, which will release LH and FSH. This will act on ovary. Ovary will form estrogen, and once ovulation occurs, progesterone is formed. Both of them, they act on the uterus, and from the uterus menstruation occurs. So all this intact, this whole tract should be intact for menstruation to occur. If there is a problem at any of these levels, a female will not be able to menstruate. So the causes of amenorrhea, whether it is primary amenorrhea or whether it is secondary amenorrhea, they can be broadly classified into 4 compartments. For example, first compartment is uterus, that is compartment 1. The second compartment is ovary, which is compartment 2. Third compartment is pituitary, which is compartment 3. And then we have the fourth compartment, hypothalamus. Now the causes of primary amenorrhea, they can be compartmentalized. For example, the cause of primary amenorrhea, which is related to compartment 1, they are Mullerian anomalies, Mullerian agenesis, and testicular feminizing syndrome. Testicular feminization syndrome. The chromosome number of Mullerian agenesis is 46XX, and chromosome number in testicular feminization syndrome is 46XY. In compartment 2, ovarian causes, the most important causes are Turner syndrome, 45X0, pure gonadal dysgenesis, 46XX, Sewer's syndrome, 46XY, and Savage syndrome, that is resistant ovary syndrome. In compartment 3, that means causes of pituitary, they are number 1, tumors like craniopharyngioma and Chiari-Frommel syndrome. Coming to compartment 4, the causes are Kallmann syndrome. The important causes, I'm just giving you the most important causes which you have to remember. Kallmann syndrome, Lawrence Moon, BIEDL, Biddle syndrome, then Frolic syndrome, and Prader-Willi syndrome. Okay, so first let us deal with what are the most important causes or the most common causes of primary amenorrhea. The most common cause of primary amenorrhea is Turner's syndrome. The second most common cause of primary amenorrhea is Mullerian agenesis. And the third most common cause is testicular feminization syndrome. So coming to the details of all these. So coming to details of compartment 1, that is Mullerian agenesis. Now what is Mullerian agenesis? As the name suggests, Mullerian agenesis means that the Mullerian duct is not developed. Now as you can see, I have written in Mullerian agenesis, the chromosome number is 46XX. That means the genotype is 46XX. Now if there are two X chromosomes, as we discussed earlier when I was telling you in OBS that the sex of the baby is decided by the Y chromosome. If there is a sex related region on Y chromosome, SRY region, which is responsible for the formation of testes. If Y chromosome is present, the gonads are going to be testes, and if Y chromosome is absent but two X chromosomes are present, the gonads are going to be ovary. Now in this case there are two X chromosomes. So the gonads will be ovary. Now ovary they develop from the genital ridge, and in these females the problem is not in the genital ridge. The problem is Mullerian agenesis, and because genital ridge is intact, so ovary will be normal, and because ovary is normal, ovary is going to secrete estrogen. This means the levels of estrogen in these females are adequate, and if levels of estrogen are adequate in these females, I told you the hormone which is responsible for secondary sexual characteristics in females is estrogen. This means these females will have normal secondary sexual characteristics. So what is the problem here? Why aren't these females menstruating? These females, they do not menstruate because the problem is Mullerian duct is absent. Now because Mullerian duct is absent, and Mullerian duct is responsible for formation of fallopian tube, uterus and upper part of vagina, so it means all these three things will be absent, and if there is no uterus, the female cannot menstruate. Now where is the lower part of vagina formed from? The lower part of vagina is formed from urogenital sinus. Therefore in these females, vagina is like a small blind pouch. Now when the Mullerian duct develops, okay, I'm erasing this. When the Mullerian duct is formed, it grows from above downwards, and it leads to the formation of fallopian tube. Half of the uterus of one side, if this is left side Mullerian duct, it will lead to left side fallopian tube, left half of the uterus and left upper part of vagina. And similarly, the right side Mullerian duct will form right side fallopian tube, right half of the uterus and right upper part of vagina, and then there will be a fusion, and this results in the formation of the two fallopian tubes, uterus and vagina. This wall between them will dissolve. That is how uterus, fallopian tube and vagina are formed in a female. Now, if Mullerian duct is absent, ideally it should be that fallopian tubes should be absent, uterus should be absent and upper part of vagina should be absent. But in few cases, the distal part of fallopian tube can be present. The reason for this is that Mullerian duct grows from above downwards. So if it is growing from above downwards, fallopian tube can be present, but vagina and uterus will not be present. So if in the question they say that MRKH, yes, Mullerian agenesis is also called as Mayer-Rokitansky Kuster-Hauser syndrome. MRKH syndrome. Now if the question says MRKH syndrome is characterized by all except option A, absent uterus, option B, absent vagina, option C, absent fallopian tubes, option D, absent ovary, you know the answer is absent ovary, because ovary will be present because Mullerian duct does not lead to the formation of ovary. But suppose the question says that all of the following are seen in MRKH syndrome except option A, absent uterus, option B, absent vagina, option C, absent fallopian tube, and you have to answer amongst these only. Then you can rule out fallopian tubes, because in some cases distal part of the fallopian tube can be present. The reason I have told you just now. Now because Mullerian duct, they also take part in the formation of renal system. Therefore in MRKH syndrome, in 20% cases there is associated renal anomalies, and the most common renal anomaly which we see here is horseshoe shaped kidney, and in 12% cases there is associated skeletal anomaly, most common being scoliosis. So whenever you are making the diagnosis of MRKH syndrome, you should also get an intravenous pylography done to rule out associated renal anomalies. Now coming to the management, how are we going to manage such a patient? Now in the management of such a patient, see, you cannot make these females menstruate because they do not have uterus, so their menstrual function cannot be restored. But what we can do is we can make these females capable of getting married, and that is we can do a vaginoplasty in these females. So the management in these females is vaginoplasty, that is the definitive management. Questions which are asked on vaginoplasty. In vaginoplasty, the most common question which is asked is what is the time at which you should do a vaginoplasty? The time for doing vaginoplasty is just before marriage. It should not be done at puberty. It should be done just before the girl is getting married or before marriage. And the technique of doing vaginoplasty is called as Mecken-Dewey technique, that is Mecken-Dewey vaginoplasty, which is a more common one. Or you can do vaginoplasty by a second technique which is called as Williams vaginoplasty, but that is not that common. The more common and the better technique is Mecken-Dewey vaginoplasty. In those females in whom there is at least 1 centimeter of vagina, you can also try using Frank dilators. You use these dilators and to increase the size of the vagina, but that is not a definitive management. If the size of the vaginal pouch is less than 1 centimeters, or if Frank dilators they fail, you have to do a vaginoplasty. So the definitive management always is vaginoplasty. These females, because they have got adequate amount of estrogen, no estrogen replacement therapy is required. As far as their fertility issue is concerned, because their ovary is normal and the levels of estrogen are normal, these females are ovulating normally. So what we can do is we can retrieve their ova and we can suggest them for surrogate motherhood. That is the only way in which they can have their own genetic child. Another thing which I want to point out here is, because the chromosome number in Mullerian agenesis or MRKH syndrome is 46XX, so what will be the number of Barr bodies? You know that the number of Barr body is number of X chromosomes minus 1. That is how we calculate the number of Barr bodies. So again, these are normal females, they have got 2 X chromosomes, so the number of Barr body in these females will be 1. This you should remember, because next syndrome which we are going to do, we are going to refer back to this. So coming to the second cause of primary amenorrhea is in compartment 1, that is testicular feminization syndrome. I hope you've all understood what is MRKH syndrome. Now, testicular feminization syndrome. In testicular feminization syndrome, as I have shown you in the chart, chromosome number is 46XY. That means their genotype is 46XY. Now again, if they have Y chromosome, so the gonads in these patients will be testes. That means they are actually males. The problem here is that these males, they are insensitive to testosterone because the cytosol receptors of testosterone are absent in these males. So the problem is the testes, they are secreting testosterone normally, but they are insensitive to testosterone, as the cytosol receptors for testosterone are absent. This means because their gonads are testes, I told you that gonads, testes, they secrete 2 things. Number 1 is testosterone. Now these males, they are insensitive to testosterone. That is one problem. Then I told you that testes, they also secrete Mullerian inhibiting factor. This I told you when we were doing again a live lecture in our OBS. Now testes, because they are secreting Mullerian inhibiting factor, that is why Mullerian duct is inhibited, and so they do not have any uterus, no vagina and no fallopian tube like all males. Now because they are insensitive to testosterone, this syndrome is also called as androgen insensitivity syndrome. Now testosterone or androgens, they are peripherally converted into estrogens. These males, they are insensitive to testosterone. Because they are insensitive to testosterone, they will not develop secondary sexual characteristics of males. But they are not insensitive to estrogen. So what will happen? They will develop secondary sexual characteristics of female. And which characteristic? I told you that estrogen is responsible for breast development. So in these males, breasts will develop. And because estrogen is responsible for breast development, their breast development is almost or like of normal female's breast development, and it corresponds to Tanner stage 4. That means breasts are well developed. Whereas for pubic hair and axillary hair, which hormone was responsible? Androgens, in females also and in males also. And because these males, they are not sensitive to androgen, that is why pubic hair and axillary hair, they are not well developed and they correspond to Tanner stage 1 or stage 2. Now these babies, because they do not have typical external genitalia of male, that is why they are regarded as females, and these male babies, they are reared up as a female. That means this is an example of male pseudo hermaphroditism. And this is the reason why their parents, they get concerned, because they do not have menarche. Obviously they will not have, they don't have any uterus, and that is the reason why they come to you with primary amenorrhea. Although they are males, their complaint will be primary amenorrhea. Now when such a patient comes to you, how are you going to manage? Number one, see, they'll be coming to you somewhere around 14 years, 16 years of age. Now at this time, if you tell these patients or their parents that they are not female babies, they are male, not babies now, they are not females, they are males, that will cause a lot of psychological trauma. So you will continue to raise them up as females. That is the first principle. Second thing, now in these patients, these testes, they are intra-abdominal testes. And intra-abdominal testes, they always have higher chances of malignancy. So your aim should be to remove the testes. That means you are going to remove their gonads. That is okay, no problem. But once you remove the testes, the problem is that testes are the source for estrogen in these females. This means the levels of estrogen will go down, and these the supposed females will suffer from menopausal like symptoms like osteoporosis, hot flushes. So what are you going to do? You are going to give them estrogen replacement therapy. And the third thing, so let us write down the management side by side. Number one, you are going to let them remain as females. Number two, because their testes are intra-abdominal, which have got high chances of malignancy, you are going to remove the testes. And because these testes are intra-abdominal, it could be that these patients present to us with inguinal hernia. Number three, because we are removing the testes, the source for estrogen is lost. Therefore, we have to give estrogen replacement therapy to them. And number four, you have to make these females capable of getting married. That means you have to do a vaginoplasty. Again, same thing, you are going to do vaginoplasty just before they get married, and the technique could be McIndoe vaginoplasty, which is a more common technique, or it could be Williams vaginoplasty. Coming to some other important question on testicular feminization syndrome. Now these days a number of named classifications are being asked, that which classification was given by whom. So the classification for androgen insensitivity syndrome was given by Sneaker. There is Sneaker's classification for testicular feminization syndrome. That is one question. Second question is, incomplete testicular feminization syndrome or androgen insensitivity syndrome is called as Riefenstein syndrome. Then testicular feminization syndrome, it runs in family. These are all questions which are probable questions which can be asked. And the number 4 is, since like we say that at what is the time for doing vaginoplasty, similarly a question was once asked, what is the time for doing gonadectomy in these patients? The correct age for doing gonadectomy in these patients is after they have attained puberty. If this option is not given and they are specifically asking you the age, then according to Leon Spiroff, the correct age for doing gonadectomy is 16 to 18 years of age. Now,